Hi, this is Duncan Ferguson. This is part 4 of our series of modules on glucocorticoid therapy in small animal practice. And in this module, we're going to talk about specifically the application of glucocorticoids for immune suppression. And we're going to talk about how we can wean animals from therapy, including alternate day therapy. So what are some of the conditions that we use glucocorticoids for immunosuppressive therapy? Well, the first one is ITP, immune-mediated thrombocytopenia, autoimmune hemolytic anemia, and other autoimmune diseases like lupus, etc. And these can basically, the general principle is related to the high dosage that we have to apply. And you'll see that we're now going up to 2 to 6 or 7 milligrams per kilogram of prednisolone, and usually just to reduce the side effects, we try to divide that dose, again, to effect. So we have to set a goal, whether it's raising the platelets, raising the red cell count, or helping to treat the arthritis, lameness, and once we see that effect, we're happy with the effect, we then back off. And in this situation, the goal, of course, is to back off, and usually you can go down to 1 milligram per kilogram every other day on an alternate day basis. But there are some conditions, particularly when we're trying to suppress the immune system, where alternate day therapy is not feasible. However, you can then apply other immunosuppressive drugs in this scenario. There are some, and I want to make this point at the end of this section, this slide, that some people who believe that giving dexamethasone is better for, say, for example, treating immune-mediated thrombocytopenia, that may be their clinical impression. And in a given animal, there may be a reason that it works better than an equipotent dose of prednisolone. But as a pharmacologist, I haven't seen the data to support choice of one or the other. Now, certainly later in therapy, when you worry more about using a shorter acting or intermediate acting drug for moving to wean the animal and go to alternate day therapy, you should pick an intermediate acting drug like prednisolone that can be used for alternate day therapy, whereas dexamethasone is too long for that application. So the principles of immunosuppressive therapy are to become comfortable with glucocorticoids where you understand the side effects and you feel like from the literature their effects are well documented. So you want to use a high dose at the beginning until signs abate, and then you decrease in increments. And usually, as I said before, you can reduce the dose down to about 1 milligram per kilogram, equivalent of prednisolone or other drugs like it. You'd have to use prednisone, or hydrocortisone, equipotent amounts on alternate day. And generally, you tend to reduce side effects by going in alternate day therapy, and you don't really need to reduce the drug dosage that much further. Continuing our principles about immunosuppressive therapy, it's important to recognize that an autoimmune disease in particular has a cycle, in terms of its activity on the animal. And you need to ride that cycle out. So usually it will take maintaining glucocorticoids for at least several months in remission. Otherwise, you're more likely to see recurrence. You can add other non-steroidal immunosuppressive drugs, such as cyclosporin, if glucocorticoids action is limited. If you see no response to glucocorticoids, however, the likelihood that cyclosporin will work or other immunosuppressants will work is less. If you see side effects of glucocorticoids, then you may want to replace some of the immunosuppression with other drugs and decrease the steroid dose. But realize that glucocorticoids, through their action on the nuclear receptor, basically the nuclear receptors can adapt. They can actually result in reduced number that's called steroid tachyphylaxis. So your receptor numbers will downregulate and the effect will sometimes go away. And the general rule of thumb is that if you're just using glucocorticoids, that effect could last maybe 6 weeks. And then after that point, you're going to have to be working with other drugs as well. So it's a tricky business to try to keep that maximal glucocorticoid activity. I thought I'd throw in just what we call chronic palliative therapy. It's not something we need to do that often anymore with improved NSAIDs. For instance, treating chronically certain types of arthritides. And the point here to be made is that you can see animals go on glucocorticoids, and if you use them on and off, the off time, you may actually see signs of what's called pseudorheumatism. That is, they're really reacting to that reduced steroid dose and not showing a manifestation of the underlying disease. And of course, and this is a situation where I think you can move the animal from glucocorticoids to a non-steroidal analgesic. Now, of course, we have to be concerned about the ulcerative potential there, and there are guidelines for that. But though I wouldn't call it, as many people do, an absolute no-no to have glucocorticoids and NSAIDs in the same animal, as long as you're monitoring the animal for what you know are the side effects of GI ulceration. So let's talk about alternate day therapy. Why do we want to do it? Well, first of all, the hypothalamic pituitary adrenal axis and its suppression are associated with side effects. And so if we can minimize that suppression or move the animal back to, at least on an alternate day basis, having a normal rhythmicity of this axis, you can see reduced side effects and still have the benefit of potentially controlling a disease across 2 days with one dose or 1 or 2 doses on the first day. So the guidelines for this are really quite empirical. You can you want to start high, you want to induce the therapy, and then you start reducing it by some rational reduction, and you always asking the question, is the disease coming back? Is the animal showing side effects? Is the disease coming back? And then just generally becomes a concern only after 2 weeks of, or more than 2 weeks, I should say, of prolonged therapy. Less than 2 weeks, we usually can take the animal go ahead to alternate day therapy right away. If the animal has signs on the off day that sort of suggests that your approach here isn't working, and if you have other drugs that will lead to the same beneficial effect, you should use those in the off day. And then generally it's felt that if you can't use alternate day therapy, giving once a day therapy is the next best thing. In this graphic, we're trying to demonstrate the fact that glucocorticoids control disease. They don't cure it. And so with a disease like an autoimmune disease, we're showing disease activity on the y-axis and time over the x-axis. So you make the point of, first of all, recognizing that anything above this line means there's disease present, and this is no disease in this area. So initially you have clinically apparent disease, so that's here in this section, and you beat the disease down with glucocorticoids, the maximal dose, whatever it is. And then you could go to the single day dose as an intermediate step, but once you get the disease under control, that is, it's below this clinically apparent line, you can then have a possibility, it's not a certainty, a possibility of using alternate day therapy. But you can see on the day off, the disease activity does go up. It just doesn't rise to the level of clinically apparent activity. And so you need some diseases, you can accomplish this, and some diseases you're going to see this swing up above the level of clinical activity, in which case alternate day therapy doesn't work for that patient. So what are some of the most common pitfalls, at least that I hear about, for use of alternate day therapy? First of all, you can't expect to use it as primary therapy. You need to use a full dose every day. The other mistake is going out and trying to move to alternate day therapy while still using long-acting preparations. Hopefully our section on the pharmaceutics in section module 3 would help us explain that these are too long to allow relief of the HPA axis on the day off. The other is moving too quickly from high doses daily to try to go to alternate day therapy. The animal needs to be weaned first and then go to alternate day therapy. And finally, particularly with good NSAIDs and with other good immunosuppressants, we should be able to move the animal down to a low glucocorticoid dose and then take them off and replace by an NSAID, or in the case of immune suppression, supplement the day off with another immunosuppressive drug like cyclosporin. So let's turn our attention to recovery from exogenous glucocorticoids. And I thought it would be useful for everybody. We're all human beings, and so we need to know what happens in us. What data is there? Well, first of all, you can see a very long timeline following the termination of glucocorticoids starting here at month 0. It takes, in a human, about 6 months until the cortisol levels at basal level will rise into the normal range. And what's happened before that, it's been anticipated by ACTH going up, and eventually cortisol falls well into the normal range over here, and ACTH eventually falls again, also into the normal range. So if an anesthesiologist asks you the question about glucocorticoids in your history, they're concerned anytime it's within the previous year, and they want to know about the dosage as well. So what data do we have in the dog, for example? And this is a study a while ago of the administration of prednisone at replacement dosages, at anti-inflammatory dosages once a day, and anti-inflammatory doses an alternate day. And you can see what we're graphing here is that section of the adrenal gland, the zona fasciculata and reticularis, which I said makes the glucocorticoid, so that the fasciculata and reticularis and arcuata are the same. So you can see there's a suppression, even with alternate day therapy, of the normal size of the adrenal gland. There's atrophy. Carrying this idea further was a study by Moore and Honig that suggested that an anti-inflammatory dose of prednisone given for 5 weeks would obviously suppress, within 2 weeks, it suppressed the ACTH and the endogenous ACTH and the exogenous ACTH stimulated cortisol, that is the stress response, but the response was completely recovered within 2 weeks. So this is much different than it is in a human, and we're very fortunate that we, at least with this dosage, this duration of this drug, we have recovery in a very short period of time. We cannot assume that this is true for longer acting glucocorticoids or longer duration of therapy. And this slide is really just to show the data that we summarized in the previous slide. So what we're looking at here is cortisol, basal and stimulated in each case. And you can see that after 2 weeks there's suppression. It sustains itself at 4 weeks, but 2 weeks, and this was the earliest time evaluated, pretty much back to normal. So that ACTH stimulation of cortisol pretty much comes back to normal, which suggests the animal can respond to a stress even after a month of suppression, which is pretty astounding. As a clinician, what could you see with an animal that might be weaned from glucocorticoids too quickly, that is, having some form of glucocorticoid withdrawal? Well, I list signs for you here. Many of these are sort of almost anthropomorphic extraction from what is known to happen in people, but certainly you could expect that the animal's activity levels would be reduced, they would be weaker, essentially showing signs of glucocorticoid deficiency, which looks very similar to an animal with Addison's disease without the electrolyte changes. And in this table, this is something we don't have to do very often if you take a good drug history, which will allow you to help rule in or rule out previous glucocorticoid exposure. But sometimes an animal will come to you and you don't know the history, and you're kind of wondering what's going on. You can do an ACTH stimulation test, sort of like that study we showed, and here's some guidelines. So you would hope that an animal given endogenous ACTH would have a normal cortisol, and it would be able to at least raise its cortisol up to twice what it was before. And that would be considered a normal response. If the animal has been exposed to glucocorticoids and can sustain normal basal levels or pre-ACTH levels of cortisol, but is not able to respond with an adequate post-ACTH response, you need to consider that this is what would happen if the animal's stressed. And so in that case, you probably ought to continue or have the owner continue to supplement the animal when that animal is stressed. And finally, if you see a diminished p-value in a poor response, then that means you need to go back, continue weaning the animal, and then supplementing the animal, continue supplementing the animal when it's stressed. So what is stress coverage? Well, this is, when we give glucocorticoids in a situation where they're missing, and we know that things like mild stress, a visit to the vet, minor surgery or anesthesia, would require the body to come up with more glucocorticoids. And there are various reasons for this, but it's just part of the stress response. And so I've laid out some dosages for you here as you can consider. In severe stress, things like major surgery, we may need to go even higher than that. And it sounds like it's counterintuitive. You want to have the animal heal, et cetera, but if the animal isn't able to maintain its blood pressure during the surgery, you've got a problem. And so the idea here is you maybe start a little bit before surgery. You can give it the night before. You can also give it the same day and have some in the drip, hydrocortisone. The idea is you taper it very quickly if the animal does fine. We now have really good evidence to suggest that no matter how you give glucocorticoids, whether it be intra and sublesionally, intra-articular, topically, otically, and then ophthalmically, they all have systemic effects that have been shown to suppress cortisol, and particularly the response of cortisol to ACTH. So consider that these animals have systemic effects of their glucocorticoid. So to summarize all of our glucocorticoid modules, there's a few things I'd like to leave you with. And first of all, recognize that the pharmacology we try to take advantage of is really an extension of the physiology. From a clinical perspective, it's useful to classify the usage of your glucocorticoid according to that classification of physiological, anti-inflammatory, immunosuppressive, etc. When you're using glucocorticoids, consider that for maintenance therapy, you can use alternate day therapy, but never use it for induction therapy. And recognize, as we said in the previous slide, that HPA suppression occurs with all routes of administration. But realize we have some things that are going for us as veterinarians that we're lucky that we don't see significant clinical iatrogenic adrenal suppression, and yet we need to be aware that it can happen and that we should be very concerned about our patients, making sure they have adequate glucocorticoids, particularly when they're stressed.